Deb Rothenberg and Malia Haddock. Again, I think most of you know Deb and I, family medicine doctors up at Portland Family Medicine. Deb also does at the Learning Collaborative, takes care of a lot of their residency curriculum, and I kind of head up the medical student efforts and do some of our outreach work, which you'll hear a little bit more about later. And then Malia has been a really key member of the team for a long time, and has been the leader of the Homeless Health Partners formerly, and just recently transitioned to her new role as a psych NP over at Maine Med with the psych consult service. But she's kindly graciously agreed to help us today, chat with you guys about kind of what we do and what we've been doing, and what COVID has been like and these kind of things. So as Beth alluded to, we really are here today to try to familiarize people with what we do. So we really want this to be an interactive discussion as much as possible. So we'll be monitoring the chat box. You know, with this many people, it's tough to pipe up and ask questions verbally, but please feel free to get them in there. And we'll try to pause and address as we go. So we're going to start here with a little icebreaker. And this one I encourage you to unmute yourself. And I don't know, I use this picture a lot, and I think probably a lot of people have seen it. So don't make me cold call on people. But if someone wants to unmute themselves and tell us what this picture is about or what you see in this picture.
I hope it's not that.
I can go. It's Vicky. I think it's supposed to show equality because they kind of all have an equal little box they could possibly stand on, but it's certainly not equity because they can't all see.
Right, exactly. So, exactly, yeah, and that's really just the picture that so on the left, the initial picture that we showed you, that giving out all these resources is wonderful, but you could give, you know, maybe this person on the far left of the picture doesn't need any boxes to begin with, and the person on the far right you could give 100 boxes to. But if you're not a little more intricate in your thought and how you approach trying to get this person to be able to see the game, then you're going to be unsuccessful, and that's all. That really sets the tone for a lot of what we do down at the Learning Collaborative and how we think. So thanks. That's a great answer. Deb, you want to do the next slide? So this first picture here is just to familiarize everybody with the community. This is Bayside. To try, Deb, I think is gonna, can people see Deb's marker there? Yeah, so what Deb's pointing to right now, just like to the left there, is the entrance to the Learning Collaborative. So that's Portland Street, that's running along where the marker is, and then to the left it intersects Preble Street, and if you went up there you'd hit Congress, and Family Medicine's off to the left over there. If Deb comes back down with her marker, Preble Street, this kind of square building right here is Greater Portland Health. Greater Portland Health is a really important player in the community. They're the federally qualified health center, so this is the clinic that really serves as the primary care physicians for the majority of the people experiencing homelessness that we work with. And so again, they're a federally funded safety net program that we work very, very closely with. Then directly across the street from that is Preble Street itself, and Preble Street being, you know, a really large social service agency that does all sorts of things, from caring for veterans to housing support with the Housing First sites that we'll talk a little bit about later. In the back here, where these like little yellow awnings are, is historically the entrance to the soup kitchen. You know, this is all mobile now, so they're bringing meals out to people. And then people might also recognize that little space in the front kind of triangular corner there, which used to be a courtyard where a lot of people would spend the day. I think those are the main. And then sorry, one other important thing, if Deb kept bringing her thing on Oxford Street to the left. Oh, I think Deb's trying to point Bubba's to you out over there on the right. But then on the far left over here, like we're off screen, would be where Oxford Street Shelter is, just another block that way, where the majority of patients that we see are staying at night. Any other things, Deb, that you want me to point out? I think those are the big key, the big people in the area. And the other important point that we wanted to make about this picture is that in a very small area, you have a few organizations. You have a place for primary care, and as we all know, family medicine is probably about a mile away from there, up and to the left. And so in 2017 and the years shortly there before, without getting too much into the history of it, the community felt that there really was enough primary care and enough medical homes to take care of this population, and that maybe that adding an additional place to access primary care really wasn't the goal, but rather that the goal, kind of two goals, one being to fill the gaps. We all know that patients that we work with still do have a lot of barriers to accessing healthcare. So to fill the gaps, and then be equally, or maybe even more important in other ways, to really educate tomorrow's caregivers about how to navigate all of these issues. So in 2017, the Learning Collaborative opened up with those goals in mind.
Thanks, Adam. Anybody have questions about, be sure to put them in the chat with questions about the neighborhood or anything that Adam has said so far. This is a picture of our front door on the January that we opened. And we did, as Adam said, open to couple medical education with providing on-site low barrier access. And really that's the key, is the low barrier access to complex coordination of care, which is, you'll see in a little while why the homeless health partners are basically key to all that we do. And basically we were opening in response to a community need, as well as a graduate medical education need, to educate Maine Medical Center residents in social determinants of health upstream outside of the hospital. Oops, sorry. Not sure why this does this, but it makes me, okay.
Okay, is this,
yeah?
Can you hear me?
Mm-hmm.
Okay. Okay, so just briefly to talk about the really the scope of the problem and how we define the problem of homelessness, and it really the scope of the problem depends on how you define it. So this is sort of recent data from November of last year, sort of quantifying the number of individuals experiencing homelessness in Portland. And as you can see, it's a pretty, relative to the sort of the concentration of services that we have in Bayside, it's a relatively small number. And I think that this really goes to show that how we count homelessness really will depend. It's really going to determine how honestly we account for how many people have experienced unstable housing in our community and in communities everywhere. And so there is, and again, not without going into like too much detail, there is a definition of homelessness that is provided by HUD, Housing and Urban Development at the federal level, that says that an individual is experiencing homelessness under very strict parameters. So this type of homelessness would account for individuals who are staying in an emergency shelter. It accounts for people who are sleeping outside, and we would call those individuals experiencing unsheltered homelessness. It accounts for individuals who are staying in a building that's not designed for human habitation or in a vehicle. So we see a fair amount of patients who are living in a car, living in a storage unit, living in sort of an abandoned building, and that sort of counts towards the federal definition of what it means to experience homelessness. What it doesn't account for are all the sort of creative ways that people try to avoid homelessness, as you know, as we commonly think of it. These are folks that are staying potentially in hotels short term or sometimes long term. It doesn't account for people who are doubled up with friends or family. And you know, there's the more common term that's used is couch surfing, but you know, at the collaborative we prefer doubled up. So if you don't have a stable place to live that is your own, and you're instead sleeping, you know, in the basement or on the couch of a friend, that would, you know, according to our definition, account for, you know, that would qualify you as having unstable housing or experiencing homelessness. So generally, when we have we generate these counts of homelessness throughout the country, and if you notice, you know, in years to come, they're called a PIT count, a point in time count or survey, and this is communities mobilize all through the country, teams of individuals to count people who are experiencing homelessness according to that HUD definition. And so that happens on one night a year in January. And those numbers are important in that they help to sort of determine funding from the federal government that is allocated to you know, local communities to engage people who are experiencing homelessness.
And thanks, Malia, that we have a lot of data that show that there's health disparities for people experiencing homelessness. There was a study, I think a couple years ago now, that showed differential outcomes in cardiovascular disease for people experiencing homelessness, higher morbidity, less use of invasive procedures, etc. And in the most recent health crisis, we don't have data from Maine, but data from elsewhere in the country, this one's from Minnesota, shows that people who are experiencing homelessness are hospitalized at a much higher rate and actually in the ICU at a much higher rate. So healthcare utilization, which is one of the things that the collaborative was designed to try to address in terms of emergency room usage and length of stay in the hospital, etc. Healthcare utilization for people experiencing homelessness who have COVID is significantly higher than for those who have stable housing.
Okay, so the next couple of slides, we're going to talk about the work that we were sort of designed to do and intended to do prior to COVID, how we changed in response to COVID, and then talk a little bit about who's on our team and who's sort of on the ground doing the work, and then sort of transition into how you can connect with people who are doing the work to, you know, if you're aware of somebody who, you know, you're taking care of in whatever capacity that you're in who has unstable housing, how you can get them sort of linked up and connected to services at the collaborative if you think that would be helpful. So, you know, as both Deb and Adam talked about earlier, the goal with opening, you know, we have a sort of a dual mission at the collaborative to involve interdisciplinary learners in the care of underserved patient populations as we sort of address unmet needs in the community. And so we have sort of a very narrow scope in terms of what we're able to do for patients medically on site, but the idea was to make the services as accessible as possible. And so sometimes that's referred to as like a low barrier model or a no barrier model or a harm reduction model, but we wanted to make it as easy as possible for individuals who are not comfortable accessing healthcare, have mistrust of healthcare systems, and just or simply haven't engaged in the healthcare system in a really long time. We want to make it as easy and sort of comfortable for them to open the door and come right inside. And so as a result of that being our goal, we sort of designed the collaborative to be pretty heavy. We have more social workers in the building than we do medical providers on a typical day. And the building is really, how we staff the building is, it's designed so that the first person a patient encounters when they come through the door is a social worker. The social worker is the person who's registering the patient, checking them in, scheduling them for a follow-up if that's appropriate. They're answering the telephone. And so we know that so often our patients almost stop at the door when they're engaging at other healthcare sites because they might come in and they're really agitated or they're under the influence of substances, and that threshold at the doorway is a really important. That's a really important place at our site, and so we have that staffed with our social work team, and that team is called Homeless Health Partners. So the way that we, in general, provide services at the collaborative is to meet patients where they're at, and that can be physically where they're at. So it could be we're meeting with them at the collaborative. It could mean that we're meeting with them in the community. We can meet with people on the street. We can meet with people while they're in the hospital, while they're at a primary care appointment, up at family medicine, at their housing first department, or literally at their unsheltered campsite. And you can see sort of examples of a housing first site on the screen, and then somebody's campsite where we're going out to provide care to somebody who is unsheltered. And so we can literally meet people where they're at geographically, but we also meet people where they're at in terms of what their priority, what their priority is in the moment. And so even though a patient might be presenting to us and they have uncontrolled type 2 diabetes, or they're actively psychotic and need access to their medication, what's most important to them is they might need a shower, or they might need breakfast because they haven't eaten in several days, or they might need a clean pair of socks. And so what we try to do is seize the opportunity of the moment with a particular patient in a particular point in time, and use that to sort of build trust and establish rapport with them, knowing that the goal might be for them to establish with primary care, or get meet with a diabetes educator, or meet with one of our fourth-year psychiatry residents so that they can kind of get back on track medically. So when the work that we do at the collaborative, it can, if you were to just drop in on any given day, it might not look like traditional healthcare. It might look like us sitting down and, pre-COVID, sharing some food with a patient, or going on a walk with them, or literally just sitting outside on the curb and trying to de-escalate somebody who's agitated in the moment. But everything that we do is intentional, and even though we might not know what the eventual outcome is, the goal really is to build that trusting relationship so that we can work with them on what we might know as social workers or medical providers. Like there's really something that we have to address. It just might take a little bit more time to do that. Deb, am I next? This might have printed out.
Yeah, no, I just was going to add before I change the slide, Malia, thank you. That was really great description of who we are and what we do. And the middle illustration, thanks to Adam for creating this, is a pre-COVID weekly huddle that we would have that included nurse practitioner, physician on site, all the homeless health partners people, representatives from Greater Portland Health and from Preble Street Resource Center, sometimes representatives, a social worker from the library or the Oxford Street shelter worker. And the whole goal is really to break down some of the silos in the community. It takes a village to help people experiencing homelessness get from point A to point B. And so part of the beauty, I feel like, of the collaborative is the ability to connect across agencies and across disciplines to do that. And that's one of the things that we try to teach the learners who come through. The residents, family medicine residents, spend 1 week rotation a year doing what we call relationship before role. This is them during their community medicine block, actually pre-COVID, making a meal at the soup kitchen. But with that, in their first year, they come for a week and learn some of the things that Malia just talked about in a really one-on-one way, that homeless health partners are guides to their learning. We don't expect them necessarily during that first week block with us to actually do any hands-on patient care. The point is to understand the situational context. There's some online modules about social determinants of health and best practices in homeless health care that we have them go through and do. And then when they have completed that, in their second and third year, they spend 1 half day, 1 office session per block, meeting with, seeing patients, actually providing clinical care at the Learning Collaborative. Just briefly, other residencies that go through with us are the 4th year psych residents are with us longitudinally for a half a day a week when they're not on inpatient, just like they are at family medicine in their 3rd year. Emergency department residents are with us every Thursday during one of their blocks in community medicine. And then internal medicine and IMPs residents also spend time with us. The pharmacy resident is going to be with us. We've tried to have other nursing and social work and really be interdisciplinary. It's been limited, as you can guess, during COVID, but that is the joint mission of what we do. Now it's you, Malia.
Okay, so to talk a little bit about changes since COVID, one of the I think one of the sort of beautiful things that happened that we during COVID is that our program was really small enough and mission driven to the point that we were able to kind of dramatically alter our programming and how patients accessed care and how we delivered care in order to stay open to take care of the patients in our community. And so I think that sort of phase in March is a bit of a blur for me, but I do know that I don't think that we were. I think we had patients not coming in the building for a day, and then after that we made it work somehow, and ultimately in large part to due to the help from family medicine, having residents and some select staff come down and help us sort of develop an operation that was safe for staff and safe for our patients. So many of you may be familiar with Maslow's hierarchy of need, which is on the slide, and already pre-COVID, the sort of the takeaway from this pyramid or hierarchy of need is that at the base of the triangle, we have our physiological needs and we have a need for safety. And what is true now, what was true when this sort of hierarchy was developed and what is still true now is that unless we are able to meet our most basic needs at the bottom, we're really not in a place to access these like higher level needs or to be self-actualized as human beings. And so pre-COVID, the Learning Collaborative was already operating quite a bit at the bottom of the hierarchy. But when COVID happened, we even more so sort of based our services right out of the base of that of the hierarchy of this triangle. And so one of the things that happened, or it's not one, I mean, so many of the services, formal and informal services that our patients relied on, closed or limited access dramatically during COVID, and that's still true now. And so all of the sort of the spaces that patients would rely on for shelter during the day and even at night were closed or limited. The sort of anchor program in the community, the Preble Street Resource Center, closed, as did the soup kitchen, and they shifted to a mobile model of delivering food and social work care. The library closed, coffee shops closed, the ferry terminal closed. People had nowhere, really, literally, to be during the day, and very limited opportunities to sleep indoors, shower, use a toilet, and access any type of clean clothing or dry clothing. And so very quickly, we, to the extent possible, tried to make our space, which we had sort of committed to stay open, available to really vulnerable individuals who maybe were not sleeping in the shelter, they were sleeping outside, or sleeping in vehicles, to be able to come in, sleep, take a shower, have access to hygiene supplies and clean, dry clothing. And we became a drop spot for hot meals so that people could have food without having to kind of schedule their days around, where do I find the food truck, essentially, in the community. And so while we're still providing social work services, medical care, psychiatric care through the residency programs, and addiction medicine services through the fellowship, an enormous amount of our time is devoted to ensuring that people have those physiological needs met so that they can feel safe, and they do feel like they have a place that is available and accessible to them, where they belong in the community.
And just before we switch to the next slide, a shout out to Family Medicine for helping us do that. I don't know if you can see, but I think that's Tanisha in that, and Lindsay under the tarp there. Really helped with our ability to, this overused COVID word, but pivot our activities so that we could screen people outside and safely bring people inside who needed our services. So gratitude all around and Pete was another person, and Kaylin as well. Anybody who still wants to spend time, we're willing to have you. And so the last 6 months worth of just to give you an idea of the kind of work that we've done in the last 6 months during COVID, a lot of HHP, that's Homeless Health Partners encounters, and a way increase in our addiction fellow visits. And that is not just the addiction medicine fellow, but also the other providers here who have shifted to providing low barrier access to short-term medical assisted treatment as we try to get people into opioid health homes. Those are the medical assistant encounters and resident encounters. What's not here, there's a new smart phrase that we have that's going to count the number of showers and bathrooms and socks and nutrition and other things like that that we do. So these numbers are from Epic, and that number is not yet in a what is it called, smart data element phrase that can be counted, but that was a lot of the work of what we did. And continue to do. And this is who does it, Malia.
Yeah, so wanted to be sure to sort of introduce you, like to the extent possible, to the team, on the ground, on site at the collaborative, and in particular, there are a couple of blank spots. So I believe today Donna's first day. Yeah.
Absolutely.
Okay. So
yes. So
so
we don't have a picture of her yet.
Yeah. So we'll have a full-time family nurse. Oh, wonderful. Okay. Hi, Donna. Family nurse practitioner who is, we've been without a full-time nurse practitioner for quite some time, and this is an exciting and important day for the collaborative to have Donna on board, because when we had a full-time NP, she was the touchstone for our patients, our providers in the community, and it was just sort of like a grounding force for all the work that we were doing. And so welcome to Donna. And you can see, it's blurry on this giant screen I'm looking at, but we have Julianne, our medical assistant. We have our amazing attendings who spend fractional time at the Learning Collaborative and do sort of amazing work within limited hours. And then we have our Homeless Health Partners team, and this is our small but mighty team of social workers that are we're sort of proudly not a clinical program, and are designed to truly meet people where they're at in the community, emphasize relationship building with our patients, and to partner with them to work on what their goals are. And just like I had said earlier, sometimes those goals might seem small, like getting somebody a pair of reading glasses, and other times they're huge. They're helping to get somebody into their first apartment or into assisted living, and just being there with this sort of positive, unconditional positive regard for the patients that we take care of.
And this little period up here is not an error. There's a dot phrase that I will share with people that will get you to this very picture, so that you can have context for patients when you want to reach out to us. And you'll know that we're working with them by looking in Epic. Adam, I think it's you.
Yeah, and so as we've alluded to a couple of times, that we're in Epic, which is a very significant thing for being able to make some of these issues and our patients more visible to the system. And we've seen that work out so well so many times, especially there are endless examples of ED residents who have rotated with us that know to look at these notes and get a sense of what's going on. And I feel like family medicine is doing a really excellent job at kind of picking up traction in that too, and checking out some of these encounters. I think that maybe a couple of like key takeaways when you're looking at a chart that has a million MMC, PSLC encounters is usually, if there were a little more here, you could kind of pick out a trend of who that kind of key person is in the patient's life, who is able to always have a beat on them. And if you need labs or stat results that you're trying to track someone down, that person that's running that encounter is going to be a really wonderful resource for you. And we are always open to communication. I think the next slide, staff message is great. Where everyone's using the Epic chat now, so don't hesitate to do that. And this is our newest feature, is our pool, our MMC PSLC pool. So feel free to route things like that you'd like some input on, and we're happy to contribute as able. Anything else? I think.
No, I think. Thank you. I think basically that's a great new picture, Adam. I love it. We hope we answered some of the questions that people sent us in before. We reached out to ask if people had questions. We tried to include most answers to those, but really want to reserve the rest of the time for feedback or questions from all of you.
Thanks, team. That was awesome. And while Malia was struggling with her audio, I was struggling with my visual. So now I'm on the phone. But I really appreciate this, and definitely want to open it up to folks to ask questions, find out more. There are no wrong or right questions. This is about learning more about what we do at the collaborative, and also about our population and how we can best serve them.
This is Tina. I think that was just so stupendous to sort of hear from all dimensions where that's going. And I'm wondering if you're noticing any trends about where the individuals who you're currently serving are coming from. Are they the same population that's always been in need here in Portland? Are they new people, newly having lost their stable housing? Are they coming from other parts of the state or from other states? And I'm just sort of curious what the trends are right now.
Malia, I'm going to let you jump in on that, but I would say yes to all of those. It would be my initial answer, that we're seeing people who are new to homelessness. We're seeing people who are traveling here from other states. We're seeing some newly arrived people. We're seeing people who, there's a lot of people who are unable to access the shelters. And as word gets out that we do provide low barrier access to medical assisted treatment, we're thankfully attracting people who want to get into care for that. I guess that would be my answer, but you, Adam or Malia, if you have other things you'd want to add.
Yeah, I would say that particularly at the beginning of COVID, we saw, and I don't have numbers to sort of attach to this off the top of my head, but the pandemic really sort of exposed a vulnerable population that has just been getting by. Really just barely hanging on to their housing, just barely able to pay their bills, just barely able to get enough hours at work in order to meet their most basic needs. So I would say for a couple of months, one of the ways that we shifted the work that we were doing is we helped a lot of new patients that had never been to the collaborative before apply for unemployment. That's an example of something that prior to the pandemic, maybe we would, very occasionally help somebody do that. But starting mid-March, that was essentially a full-time job for 2 of our social workers. And then helping individuals who were newly homeless, had either never been homeless before or who hadn't been homeless in years, sort of apply for general assistance to get a voucher for a hotel room. So we also saw people, from out of state, people kind of attempting to flee more, prior to sort of the surge in Maine. Maine was sort of we had a low transmission rate, and we did have people, sort of trying to flee areas where they felt that they were unsafe, and individuals who had been sort of transient in the past, and so it wasn't highly out of the ordinary for them to come. But yeah, so I would say a lot of local people who COVID just really shined a light on how precarious their situations were.
Thank you. There are 2 questions in the chat, so I want to make sure you see those. Can you all see those, or should I read them?
Yeah, I can read them.
Great, thank you.
So question 1 from Corinne was, who's part of the new EPIC pool, and some examples of when we should think to use them. We're all attached to the pool. I would say that examples of times to use that. I think that trouble getting in contact with patients is probably a really great thing that we can help with. I think probably someone that you have newly identified as needing these services, and you've tried to use kind of our more typical sort of resources in the office, and still people are trying to get in touch with someone because they don't have a phone, they don't have a stable address. I think it's always worth to check and see if someone in our team knows the person, because more often than not, we have someone that will recognize the name or the face. Do you guys have some other examples that you'd throw out there?
I guess I would just say that thank you, a shout out to Amber for creating a workflow by which residents who connect with patients here who don't have PCPs and they want to become their PCPs, we would communicate, the resident would communicate with staff with admin staff at Family Medicine, and this would be a way to reply to all of Preble. Everybody's attached to, we tried to make it simple so you didn't have to figure out which pool to send something to. We just have one pool. All the providers that you saw on that other screen are attached to that pool, and we figure out where it needs to go from there. So no such thing as a stupid question or reach out from there, whether it's somebody who's already connected to us or somebody who you think should be connected to us.
And the next question is from Lisa. If someone arrives there and has a PCP, do you refer them to the PCP or just choose to evaluate and treat? I can go, or if you guys have.
Go ahead, Adam.
I mean, I think that the Learning Collaborative really, the kind of your typical algorithms of medicine don't apply. And so it really depends on the situation. You know, a lot of people may very well have a family med PCP, for example, but even though to us it seems like, you know, coming up to a mile away to family medicine shouldn't be a big deal when you're struggling with all those things that Malia's talked about on Maslow's hierarchy. You know, getting all of your belongings a mile up the road is huge and a huge barrier. So we certainly are understanding of that, and sometimes it means you know, that we need to work on those basic needs for several months before we get someone engaged, and certainly in that meantime we're trying to do the most we can. You know, we're not a medical home, so we don't have an X-ray and we don't really have lab services, but we can check a blood sugar, and so that's like something that we've done really effectively with some patients in the past. I think, and then a lot of people that, I should just say, people that don't have PCPs, that's always a high priority thing, is to try to get them, and that is always the ultimate goal, is to try to find where people fit best into the system. And, you know, is family medicine or Greater Portland Health, based on location and sort of the structures of those different organizations, what's the right fit? Yeah.
Other questions? I give people just a couple moments because sometimes it's hard to unmute.
I have a question.
Sure.
I was just wondering, so I know like at the office we experience a lot of people who are homeless who sleep out back by the dumpster or just to hang out, or they actually even come into the office to look for resources. Are those people that we could refer down to the clinic?
Absolutely.
Absolutely, yes. Those would be people to refer down to us. And
That's such a lovely.
Sorry?
I was going to say that's such a great idea, Amber, and so much better than trying to think about like, oh, how do we move people, right? We send them to a place where they can get services. And is there something that Amber and the team at the Portland Clinic or any of our other clinics could actually hand to people to show them where the Learning Collaborative is? And maybe what services, like something just like a card or something?
That's a great idea. We do have one of those 1/3 little cardboard things that explains who we are and what we do and has our contact on it. So we should bring some of those over to Family Medicine. And you should know that we are a no appointment walk-in. The only thing we make appointments for is for our psych residence appointments. Otherwise, we're pretty much a walk-in, open now during COVID times, open to clients from 9 to 3, 5 days a week. And those would be great things for people to send our way, let them know that we're always welcome to walk in, or to send us a little message about that person, because we can also try to find ways to reach out.
I would love to see those pamphlets you just mentioned go to all of our clinics. I think that's really important for people to just be aware. And obviously, you know, people who are experiencing homelessness or doubling up live all over the greater Portland area. So
yeah, we'll make it happen.
any other comments or questions? It's just about time to wrap up, but if there's one more thought, I'd love to hear it.
Adam, can you get pictures taken of the chin-up bar?
Tell the story of this?
No, not the story. We don't have time. But where's the location?
Oh, this is at Houston Commons. This is one of our favorite patients. The one.
Site.
What's that?
Just so people know that that's a housing first site.
Yeah, which is a lecture unto itself about what housing first is. But he's a great example of someone, of a beautiful story of a guy that we all got to know and love dearly, who had, when we met him, had metastatic lung cancer, but hadn't always been really established with primary care. And over the course of us getting to know him, he ended up, the long story short is that he ended up agreeing to get hospice in his final weeks, and which really enabled him to stay at Houston Commons, which is where he had grown to identify as his home, and died peacefully and respectfully, which I think was a really beautiful way for it to all go.
We're almost at the top of the hour and people are going to have to start going off to work. So I just really want to thank you again for not only the work you do, but for sharing it with the rest of us. There's a lot of awesome comments in the chat box, so I want to make sure you get to see that. And, you know, I think this highlights the fact that we have over 40 people at one point during this tuning in to listen to what you're doing. And it just makes me realize how important it is, and also how we really need to highlight our own work in the department. So I'm going to be tapping other people to come and talk about the cool things you do. So thank you so much.
Thanks for having us.
Yeah.
Thank you.
And, you know, if people want to go by the Learning Collaborative, just let one of the team members know, and they can arrange something so that you can come by and see what's going on.
We'd love that.
All right, everyone. Take